So, what abnormalities are on this set of bloods? And so, is the sodium high, normal, or low? If we just go through each of them. Normal, yes, definitely normal. Potassium? Again, high, normal, low. So this potassium is a bit on the high side, actually. We'll come back to the potassium. What about the urea and creatinine? So there is a correct answer, and then there's a smart-ass answer for the creatinine, especially. So the creatinine could be really high, or like as James mentioned a few weeks ago, it might just be someone who goes to the gym a lot, someone who's just really muscular. But creatinine is high in accordance to the normal values. They won't expect you to take that into account in an exam. In an exam, you'll just say, yes, this is high, move on. Urea? High, normal, low. So this is a high urea. So yeah, this is high. So this set of blood tests is something you will very commonly see in exams. Like, I almost guarantee that this will be one of your questions. It will be this panel of bloods, and then it'll be like, how are you going to manage this patient? So if you've got a high urea and a high creatinine, what is the number one thing that you should be thinking about? Which, if you don't know the answer, if you look to the top of the screen in the menu bar, it tells you. So what's going on here? You've got a high urea and a high creatinine. Yeah, tube Wi-Fi is really slow. Don't worry about it. Yeah, urea is high. So if you've got high urea and a high creatinine, the thing you need to be thinking of in any patient is an acute kidney injury, especially if it's happened within a few days to a few weeks. The kidney's screwed. If it's a longer term problem, then it might be chronic kidney disease. We won't really talk about chronic kidney disease today, but yeah, in the short term, if this happens, think about acute kidney injury. Which of these so we've got normal sodium, I'm not worried about that. And then we've got raised potassium, urea, and creatinine. Which of these three are we most worried about in terms of the patient? Which of these could cause serious harm to the patient within the next few hours? Potassium, yeah, absolutely. So potassium is essential for muscle and especially cardiac muscle function. So we are worried about the potassium. So we're talking about AKI today. This is what AKI looks like. First, we're worried about the potassium. And the reason we're worried about potassium is it causes these cardiac arrhythmias. And there's like a 3-step way to manage hyperkalemia. So first, I'll give you clues as we go along. So first, you want to do an investigation. So what investigation do you want to do if you've seen that someone has a high potassium on their blood test? What investigation tells us whether the heart is okay or whether the heart's struggling? Oh, so you would do an EGFR. So the EGFR is calculated from the creatinine. So you would get an EGFR. ECG, absolutely, you would do. Troponin, you would do later on if you're worried that the heart is deteriorating to such an extent that they're getting ischemia. Then you would do troponin. So first thing you're going to do is an ECG. And do you know what sign you get on an ECG with high potassium? Tall tented T waves. So if you look at the T waves, they're massive. They're not like a tiny bump like they're usually meant to be. They'll be huge. Izzy, I don't know whether you can find an image of that. I forgot to put one on the slides. Yeah, you can also get like a flat or an absent P wave. You can get like a broad QRS complex. All of these are less sensitive signs, so you will get them, but they only happen when it's a lot more severe. So the thing you're going to look for is tall T waves first, and then you're going to look for the other things. Good. Then you're going to stabilize the heart muscle itself. So there is one drug we can give to make sure that the heart doesn't go wacky and start going into arrhythmias. Does anyone know what drug we give? Calcium gluconate, absolutely. You're going to give that IV. stabilize the myocardium. So yeah, in the picture Izzy's just put on, you can see that the T wave is the last of the 3 waves, is like massive. It shouldn't be that big. Once you've stabilized the myocardium, you can then worry about getting all of that potassium back into the cells where it belongs. So do you know any drugs that can push potassium back into cells? Mechanism of action for calcium gluconate. I think it's something to do with it works on the sarcoplasmic reticulum, and it prevents it changes the, I think it changes the concentration gradient between the sarcoplasmic reticulum and the myofibrils, so it prevents excessive contraction. I'm not really sure though. Can you remember, Izzy? I think it's something to do with that.
I just looked it up, so it just increases the threshold potential, restoring that gradient. So, and it takes about 5 minutes and lasts about 30 to 60 minutes. So it's a bit of a quick acting one.
So it's really good to do initially. It's worth pointing out that, so like there's different thresholds that you'll learn about for hyperkalemia. Between one of the thresholds, you only treat them as hyperkalemic if they have ECG changes. So like 5.5, but if it's above, I can't remember the exact cutoff, it's either 6 or 6.5, you treat them even without ECG changes, because that's really, really high. That's something for you to look up on PassMed, because you can find the answer very easily there. I will look it up at the end as well if you want. So you want to move potassium back inside the cells, and there's 2 drugs that can really do that. You can give insulin, or you can give nebulized salbutamol. So interestingly, patients on like salbutamol after asthma attacks might have a slightly lower potassium than expected. Why do we give dextrose along with the insulin? You can probably figure this out. Yeah, you don't want them to have a hypo. So yeah, hyperkalemia, very important, especially in the context of AKI, but also outside the context of AKI. Fine. Here's some things that ITU consultants can do that we're not going to talk about. You can read up about this if you're interested. AKI staging. I don't think there's a good way of remembering this. I personally remember the urine outputs rather than the creatinines. This is unfortunately one of those things that you can put on a flashcard and just repeat. It won't, like, UCL is very unlikely to just quiz you on like these boundaries. They'll probably give you like blood tests instead. So yeah, I won't say more about this, but you need to know about these 3 stages. Fine. And then like causes of AKI. So what did we use? So for those of you that were here last week, we used something to split up the causes of anything. Like there's a system that we can use to split up the things by etiology. Does anyone remember what that was? Vitamin D, vitamin C, D, E, yeah. So the surgical sieve. So the surgical sieve splits things up in accordance to etiology. So what is the underlying cause? Is it a vascular cause? Is it like an infectious cause? If you weren't here last week, just have a Google, just Google vitamin C or vitamin D surgical sieve, and it'll show you all the things. I think Izzy's going to go through some examples again anyway. But that's one way of categorizing causes. There's another way of categorizing causes, which is like in terms of functional anatomy. So a good way of doing this for, yeah, absolutely. So you can do it as pre-renal causes, so problems before the kidney, renal causes, so problems intrinsic and within the kidney itself, and then post-renal causes, so any problems after the kidney. Pre-renal causes, Izzy's going to go into a bit more in a bit. So any cause of kidney hypoperfusion causes a pre-renal AKI. Renal AKIs themselves are anything that affects the filtering system within the kidney, and these are actually quite rare compared to the other 2. So we won't spend too much time on them. And then post-renal causes are just blockages of the ureters, which causes urine to build up and damage the kidneys. So that's another system you can use to categorize causes. We will do yet another system later on today. But basically, based on the presentation, you'll find there's good ways of organizing your thoughts, and this is one of them. Fine. So, I'm going to hand over to Izzy because she's going to talk about shock for a bit.
Okay, cool. Hi guys, I'm Izzy. I'm one of the fifth years. So I think we thought that it was good to combine acute kidney injury with shock, just because the kidneys are like one of the most vulnerable organs. That is kind of the first one. They're the first ones to really get knocked off when someone's unwell. So if we start, so can anyone give me kind of a vague description of what they think like a shocked patient is?
You might want to take control of the slides, but.
Oh yeah, whoops. I might want to do that. Yeah, that's like, yeah. So like low BP, tachycardic, those can be kind of some of the first signs in adults that something, they're kind of decompensating, and they're like going to slowly become more and more unwell. So I guess like the big definition that probably like intensive care doctors and stuff would use is that you've got this problem that you're not perfusing your tissues properly, and which is leading to damage or failure. And clinically, you can see this in relation to their blood pressure, their heart rate, their respiratory rate, and their consciousness. It's something to bear in mind as well that sometimes things can go up or down. So we'll go through the different types of shock, but in some of them, their heart rate will go up, and some it will go down. And so just to you can kind of use what you see to work out what is the cause of what's going wrong, essentially. So like anemias, which I taught before, it's good to have some kind of categories. So has anyone in like, your kind of like first month come across any types of shock? And don't worry about using like the medical terms, like even if you're just describing, like, yeah, it's fine. Yep, so septic shock, that's like a huge one, one that's always on the forefront of every clinician's mind when they've got someone who's unwell. And that fits into a broader category, which we can go through. And yep, so hypovolemic shock is the big one. It's like the most common. And yeah, hemorrhagic is, yeah, it's the same thing essentially. And then, sorry, yep, cardiogenic, nice. That's my second one. Yeah, obstructive, nice. And then so under kind of like septic shock, before septic shock it's under distributive. So it's just that essentially like the fluid is just in the wrong place. So septic shock is one of them. There's three others. Anyone can come across them. Hypervolemic. Oh, I don't know. I guess that you can get fluid overloaded. That is for sure. And then all the fluid goes elsewhere.
Technically, one of the subcategories causes like a hypervolemic shock, but I wouldn't describe it as a hypervolemic shock. But like, good try.
So in distributive, we've got endocrine shock, which I'll go through. Anaphylactic shock, which I'm sure like all of you are aware of, but it's just something that we don't like think about always. Septic shock and neurogenic shock. So and as I said before, hypovolemic is the most common. So got some questions. So just to start off, I think it's always good to think about what our patients are going to look like, and that is very difficult when people haven't been in resus and haven't seen what people look like, but I'm sure we can all remember from sort of Casualty and Grey's Anatomy and stuff what people can look like. So does anyone like have any suggestions of like how their appearance might change or like their clinical picture? Yeah, so clammy, yeah, sweaty. Yeah, so if it's like a neurogenic thing, they might have weird and wonderful stuff going on with their pupils. Accessory muscles, yeah, they might be breathless if there's a cardiac cause. How about, so I said that their kidneys get knocked off first. What might you notice regarding their kidneys? Yeah, so they're going to stop urinating. So like especially in the elderly are quite prone to like knocking off their kidneys pretty quickly. So you're going to have like this reduced urine output over time. So especially if the patient's catheterized, doctors will look to see how their urine has changed over, the course of days or hours. And so you're going to look at their skin. They might be pale, they might be mottled, which is where I guess maybe Anush has a good photo of it, just to kind of, because they sometimes describe them as like a dusky appearance. And I never really, whenever they said people look dusky, I never really got what they meant. And then their hands, their feet, they're going to feel cold, right? Because they're kind of peripherally shut down. Mentally, they can kind of go from a very anxious state into a reduced GCS and, comatose state if they get really ill. Yeah, so Anuja has posted a really good photo of that. And then their urine output is going to be pretty poor. And so I've kind of already talked about this, so I think we can kind of skip, but like you're going to be able to look at their general like observations, their heart rate, their cardiac output, their blood pressure, and any of these can be kind of up or down to compensate. And when someone's in shock, often their lactate will go up. Does anyone know like physiologically why that happens? If we remember that like shock is where there's a lack of perfusion to the body. Yeah, so it's more anaerobic respiration. So if they're not perfusing their organs properly, there's none of the oxygen, and so they're going to rely on anaerobic respiration, which is terrible. I can't remember how many ATP it produces, but it's a pretty poor amount. So they end up, it's a very good marker of tissue ischemia, essentially. If the lactate's up, okay, six ATP. If their lactate's up, it means they're on anaerobic respiration, and it's just not enough, really, not enough. And so, yeah, it's always good to check out the lactate if you're really worried about a patient, or it can be a reassuring marker for you if it's normal. And then we've got a photo here as well, which has some other signs on it that you can look at. So cardiogenic shock. So this is basically, in my simple non cardiologist terms, is that there's a problem with either the left ventricle or the right ventricle pumping blood either to the lungs or out of the body. And so I've given you some clues on the right as to some causes. And I think these have been touched upon in previous lectures. But if we use our surgical sieve, our vitamin D, does anyone have any suggestions of like what might cause the heart to essentially give up? So yeah, so STEMI is like the top right. And for a bonus, not a bonus point, there's no prizes, but do you know what the name is given to how you would describe what's on the right? So it's almost like the inverse of what's happening on the left. Do you know what that's called? Because that's something that can make you seem like pretty impressive to a cardiologist if you term it what the right thing is. No, so it's on the same ECG. So this is like lead 3, so this is like anterior chest, and then AVL is like, oh God, where is AVL? Anush, where's AVL?
It's AVL is like the middle left.
Yeah. So it's kind of, they call it like a reciprocal change. So it's essentially like it's all to do with the electrophysiology. So where it's raised in one area, it can sometimes be inverted in another. And it's not that they're having like a combo of two events. It's just that it's to do with the way that the deflections occur with like the electrophysiology of taking it. So if you want to seem smart, say reciprocal changes. They kind of love it. And then any ideas about what's going on with like the bottom, the chest X-ray? And even if you don't know what the like pathophys is, like there's quite a big abnormality. Pleuritis. Yeah, so heart failure. So I don't really know what pruritus would look like on a, unless you mean it's kind of a bit like, kind of, I'd say craggy. That's like literally not the word.
It's a bit fuzzy around the edges,
fuzzy,
I guess.
yeah. So
Yeah,
essentially, this person's in heart failure. Oh, pericarditis. I guess they could possibly, but we usually, when you see a heart that occupies more than, like, it's sort of verging on 2/3 of the chest, if not more, you're thinking of like cardiomegaly and heart failure. So that's kind of our big like vascular causes, along with, especially in the developing world, obstetric complications like hemorrhage. That is a massive killer of women, and is not something to be like forgotten about. Um, and like malignant hypertension can cause like disruptive bleeding and abnormal coagulation. So does anyone know what the I stands for in vitamin D and what like the cause could be in general? Or for any of the other letters, like I don't mind. Yeah, so yeah. It's not I didn't put it as the first I, but yeah, infection is one. And there's like one particular infection that can cause a heart failure. And to give you a clue, they kind of start off with a sore throat, and then they can get this kind of like fever picture. It's not very common here. Yeah, so like endocarditis is not the one I was thinking of, but that can also cause like a kind of huge septic shock, because you're firing infection off into the rest of your body. But it doesn't really, it doesn't really happen here. Yeah, so strep throat is the causative thing, but what does it cause? Something fever. This is like, I'm like seriously impressed that smashed it. Like rheumatic fever. I'm really impressed that you guys like know this already, considering it's not something like we come across. But yeah, rheumatic fever essentially can cause like a heart failure.
Just quickly, so scarlet fever is also caused by the same thing. It's just scarlet fever is less severe. Rheumatic fever is like a huge deal internationally still, because it causes severe valve disease. It's worth being aware of. But yeah, good. Yeah, scarlet fever is good knowledge too, so it's good that you know both of this.
And so the first I is something that we do. So it's like iatrogenic causes. So it could be like previous cardiac surgery. There are risks to any cardiac surgery, and that could like push you into heart failure or a complication. T, does anyone know what the like T would be for cardiogenic shock? Yes. Yeah, nice. This is like my go-to if I don't know something, but then sometimes it's just not applicable to the situation. But yeah, trauma. So that can cause a tamponade. So if you get hit by a bus, you can bleed into your pericardium, and basically just it stops the heart from being able to fill properly. And so your output's going to be rubbish, and then you can get shocked that way, essentially. So it can cause a pump failure. Cool. And then A, does anyone know what A stands for? It's like me and Anusha's favorite area of med, but you don't know us very well. So yeah, autoimmune. Yeah. So does anyone know the autoimmune condition that can occur after a heart attack? Like a patient might present like a month later with so Dreslers, so they can get this like autoimmune. Sorry, my thing has just crashed a bit, but yeah, Dreslers is a one. And by the way, just to like let you know, this is not an exhaustive list. I'm sure some of you will know like other causes that I've not covered, and we'll come across other causes. And there's not always a cause to fit every category for every condition. Like sometimes it's hard to come up with a metabolic cause. But yeah. So I think metabolic, I came up with nothing for this. So if anyone knows one, I like enlighten me for sure. Okay, and then we're on to N, which is, does anyone know what N is? Yeah, so neoplastic. So, I mean, it's pretty rare to get things like an atrial myxoma or something, but it's always a thought. But you can have like a huge mediastinal mass. So you could have like a lung cancer, you could have a thymoma that's just pressing on the heart, essentially. So these are going to be lower down in your differentials, but like never say never, right? And then I've put congenital down here as it's not always applicable to every single thing. And it's probably more of a fifth year thing because we do pediatrics, but congenital heart disease, you still get, elderly people with Eisenmengers and, patent foramen ovales that were never closed up and things. So it's always good to think about. And then cardiomyopathy, which we can do in another session, but these are kind of hereditary causes that you need to think of sometimes, but a bit lower down. Okay, onto obstructive. So obstructive, I think, is you don't need to know a whole lot about the anatomy, but just think of it as like a huge circuit and that there is a clot somewhere in this circuit for blood to go, which then prevents it either getting back to the heart or getting out of the heart or just getting stuck somewhere in the arterial system. So does anyone know any pathologies that go with any of these? Yeah, so PE is a massive one. So it has to be a big enough PE, a massive PE, but like, yeah, PE is a big one that can cause someone to quite rapidly deteriorate. I don't know if yeah. Oh, I should have given you guys more time. But yeah, why does a tension pneumothorax cause it? Does anyone know? So it's this, yeah, so it's essentially like just a humongous amount of pressure that is just going to affect all of your venous return, getting back to the heart, and possibly kind of crushing your heart a bit in the process. And so you're just not going to have that blood flow, and that is one of the very first things that is kind of checked in someone that's collapsed, is it's quite a reversible cause of cardiac arrest. So it's always one to know for exams and for life, essentially. And then pulmonary hypertension also can lead to like right heart failure, which I probably won't. I think it's quite a complicated pathology, so we won't go over it very much today at all, but something to think about. And then COPD patients can be quite hyperinflated and can get cardiac problems as well because of that. Has anyone got any ideas for the other ones, or just kind of major areas that can be obstructed? So if any of you are on RESP or have been on RESP, there's like quite a big, there's a kind of interesting pathology that causes a blockage to one of your, like to the superior vena cava, if anyone remembers it. And yeah, if like fat embolism could like, yeah, go into the coronary circulation or the pulmonary circulation. So that's a good one. Can the diaphragm constrict the aorta? I don't think so. You can have stuff constrict the aorta, like a huge tumor or something, but I don't know if the diaphragm.
I've never heard of it, but that's a very creative thought. I like that.
I think like with obstructive, just think kind of like, you don't need to know a specific thing. It's just like, could something be crushing it? And if something's crushing it, it's probably a tumor. Yeah, so cardiac, we've got tamponade again. So there is a massive overlap between obstructive and cardiac. You can kind of have a combo of the two. Because, like a massive PE can put a huge strain on the right side of the heart. And so you can get a bit of a combo of failure and also obstruction. So it is sometimes good to think outside of some like systems and just think of a kind of mixed pathology. And then I've also put like valvular heart disease, because if you've got aortic stenosis, you're going to have rubbish cardiac output. If you've got mitral regurg, you're going to have like an enlarged left atrium. and that's going to stress the heart as well. So yeah. And then, to be honest, the only arterial one I kind of came up with was like an embolus, as like someone said, a malignancy pressing on it, or like aortic coarctation, which is just a congenital narrowing of the aorta, which you can just leave for peds essentially. But we could go over it another time. It's quite interesting. And then with venous obstruction, you're thinking about what's going to obstruct, like blood going back to the right side of the heart. And so you've got your main two veins, your superior vena cava and your inferior vena cava. And I think like it'll get mentioned on rest just because it's quite interesting, but you can get certain types of lung tumors that can compress the superior vena cava and cause some quite interesting clinical signs. Cool. Like, and please stop me at any point if something I have said has not made sense. I think just take away the general concepts and like how to approach shock, like for now, and then you can kind of learn the more specific pathology, like over time. But it is very interesting. Okay, so distributive shock is essentially all your fluid, not all your fluid, that'd be bad, but like a lot of your fluid has just gone into the wrong place. And so it's not in the intravascular space anymore. It's gone into the interstitial area. So whenever you see patients, you'll see these like heart failure patients where they've got huge leg edema because all the fluid has been pushed out into their legs. It can also get pushed out into their lungs. It can also get pushed out into their peritoneum. So that's why a lot of liver disease patients have huge ascites because of these huge portal pressures. And so there's multiple mechanisms. I've put in my notes below my slides about like there's a few PubMed articles and like interesting things if you're interested in the mechanisms, but there's quite a few different options. And another one to bear in mind, which the med school doesn't really teach very much about, is burns. So you essentially just get a huge amount of like water from your blood essentially evaporating and also third spacing and causing these huge blisters. And you can lose actually quite a phenomenal amount of water from them. And I think it is definitely a fifth year thing, but if you're interested, have a read. And it's quite fun to work out how to calculate like percentage of water loss from burns. So if you're like a budding trauma person, like defo have a read, it's really interesting. So I'm just going to go through the different types of distributive shock. Pam Houston was a fantastic like teacher of endocrine disorders. So I think we won't touch a whole lot on endocrine disorders this time, but just to bear in mind like some of the endocrine emergencies that you get. So can anyone tell me what they at first see on these pictures? Don't say the disorder just yet, but like can anyone describe what they see? And you don't have to use like medical speak. And I apologize if it's like not the best photo series. Yeah, so they are kind of like plaques. It's probably because it's so small. So they're like plaques, they're more pale. What it actually is it's depigmentation of the skin, so it's vitiligo. So there's probably a better photo that Anush could get up that you can see in big. But this is an associated feature with this condition and also with like other some autoimmune diseases as well. So and what we also see on the other images is like it's quite subtle in these photos, but there's just hyperpigmentation of like the elbows, of the gums, and of the palmar creases. So does anyone know what this condition is? And if you want a clue, like a very famous US president had this condition. Who was sadly assassinated very famously. That doesn't narrow it down. There were quite a few that got assassinated, but
I didn't know that side though.
So in this condition, they have low mineralocorticoids. So they've got low cortisol, low aldosterone. Yeah, Yeah. So it's Addison's. So they've got hyperpigmentation of the palmar creases. Classically as well, you should look for it in areas of like trauma, so waistbands, bra straps. You can see these like hyperpigmentation, and then also the gums, and then they've got like some of them get vitiligo as well. There's a few other like interesting associations, but essentially like it's good to split it into primary mineralocorticoid deficiency and also secondary. So does anyone know what would cause someone to get a secondary deficiency? Or what is a common cause of an Addisonian like crisis, as it's termed, in patients? So it's them coming off a certain medication. You might not have come across it. The rheumatologists are very hot on it. Yeah, so hydrocortisone. So hold on, let me see my order that I picked up on. Okay, I will zoom through it and then I'll talk about it. So for patients that are on long-term steroids, so the classic patients would be the COPD patients with frequent exacerbations, the rheumatology patients like who have arthritis, and also obviously like, is everyone else's teams freaking out? I don't know. I think mine's okay, but okay, maybe it's my teams. Oh yeah, mine was doing that earlier. I just thought it was my rubbish Wi-Fi. But yeah, so in rheumatology, they're quite hot on it. It's why they taper people slowly off their steroids if they've had them for a short period. But also a big thing for them is obviously like your cortisol rises in times of stress. And so whether that be that they're having a hip replacement or they've been in a road traffic accident, you want to give them more of their steroid to kind of create that stress response. Otherwise, they can kind of go into this distributive shock crisis. But kind of back to the primary mineralocorticoid deficiency, your kind of common things to think about is that obviously Addison's is probably the top of your list. And in the UK, it's most commonly an autoimmune condition. But worldwide, I literally only found this out like last April, is that it's tuberculosis can infiltrate the adrenal glands. And then obviously you've got like cancers of the adrenal glands, any kind of like ischemia of them that can cause this problem. And then you've got your higher pituitary problems as well, which I think we'll probably just do another time. And then another kind of endocrine system to think about if someone's coming in with shock is the thyroid. So both ends of the spectrum can cause different presentations, and I think we'll just go over it another time because it's quite a long topic but very interesting. Sorry, yeah, I feel like endocrine shock was just a taster rather than like elaborating a lot. But essentially, the reason why they get shocked is that aldosterone basically makes sure that your kidneys retain water by reabsorbing sodium. So if you've not got any aldosterone, you're just basically going to get like osmotic diureses, and you're just going to wee out all of your water, and your intravascular volume is going to be depleted. So they're going to look very dry, and they're going to be very, very sick. Cool. So now on to septic shock, which is probably like the biggest kind of one, I guess, in the public eye, especially sepsis is quite a big one. And I think we can talk about sepsis and the management kind of separately in another session, but kind of the big take homes would be that a lot of it is caused by kind of staph, strep when it comes from a skin source. But you've got to think about multiple modes of multiple areas of source. So like urinary sepsis is quite common, can especially occur in the elderly quite over time. You've got your GI causes, soft tissue, so your septic arthritis, things like that. And then there's certain risk factors which are quite specific to each, but any patient that has a catheter in or a cannula, any kind of foreign body that's like in them, doctors are very, very hot on that because that can be a serious source of infection. And if any of you get time with the orthopods, they are extremely OCD about their theatres, because if a prosthesis gets infected, they have to do a huge washout and replace the joint, and that's obviously very detrimental to patients. And with septic shock, kind of one of the first flags is like the blood pressure. So if their blood pressure drops below 90, you're very worried. And also it's sometimes the difference between their normal blood pressure in now, so, but we can go over that. Does anyone know what this is on the right? Obviously, it's more probably related to peds, I guess, but it is probably like the classic sepsis that kind of everyone thinks about, which is ironically not caused by a gram-positive infection. It's caused by a gram-negative. Anyone got any ideas? So it's not varicella. I don't know, we've got a photo of chickenpox. So yeah, they're kind of hemorrhagic. So they'd be like non-blanching rash is the classic. So you put the glass over it, or the mum will have done, and it won't blanch because they've essentially kind of bled into the skin layer, and they are incredibly sick. And it's one of the bacterias that causes it. So does like meningococcal septicemia ring a bell to anyone? It's probably like from first year ID where like everyone was, I mean, I was just struggling through it, but yeah, I think Anush can find a photo of like another meningococcal rash, but it's basically like Neisseria. And because these patients get especially sick, that you often assume that the cause of their sepsis could be something like this, and you treat empirically for it. But yeah, that's the kind of classic rash that someone will present with. Okay, so septic shock. So there's multiple mechanisms, and I just put this photo in, not because you have to learn it, like please don't feel like you have to learn it, but just in case anyone was interested and it made it a bit easier to remember. But in general, you've got more leakiness of the capillaries, and so fluid moves out. You've got loss of kind of proteins into the interstitial space. You've got this abnormal coagulation, and all of your immune cells are going a bit AWOL. So this can cause a really dramatic drop in someone's health, and this kind of explains a lot of the symptoms. So the immune system triggers you to become like hyperthermic, but also you can become a bit hypothermic depending on the individual's response. And the abnormal coagulation causes that characteristic rash and organ damage. So you're going to want to give this person fluids, and you're going to want to escalate pretty quickly to a senior. But we can kind of go over that again like another time, because sepsis is obviously quite an important and quite a diverse topic. So anaphylactic shock is something that was covered in first year kind of ID, and in general, like the classic would be a child with a penicillin rash. But there are other drugs that can cause this, even simple things like non-steroidals in some people. So it's always key to ask in your drug history about allergies. And essentially, it's mast cell activation that causes this huge systemic response. And some of it is IgE mediated if you've got like a food allergy, but sometimes it's the drug activating the mast cells in a different way. But I wouldn't say that you need to know it particularly in detail, but just kind of know the key the key problematic drugs for anaphylaxis. And so how will they appear clinically? So being able to describe these signs is quite useful. So could anyone give me kind of a name or just describe any of the photos that you see? And particularly maybe like why I've put the top right in. And the bottom right is it's like a post-mortem photo, I think. So yeah. Yeah, periorbital edema. So that kid's probably being stung by bees. I get a vibe. If anyone see that Bear Grylls photo of him being stung by bees, that is quite a key example of that, like almost an anaphylaxis. So yeah, their eyes can swell up. Yeah, so that's a vomit bowl in the like top right, and it is important to note that like some patients will not present with these classic signs. Their blood pressure may drop, and they may be vomiting. So just because someone doesn't have the kind of classic mouth swelling doesn't mean they're not necessarily having an allergic reaction to something. So does anyone know like how you would describe the rash at the top? There's kind of a colloquial name for it. And then there's a kind of dermatology name for it. Yeah, so it could be like a raised pruritus. I think sometimes so pruritus is usually like itchy. And so they can sometimes like have severe itching and sometimes kind of not. But like, so 1 second, I think this is going to pop up from my stuff. So so hives is the colloquial name for it. But urticaria is like the dermatological name for it. And then they can get this angioedema, which is basically like fluid going into the interstitium. And so they get swelling of their lips, swelling of their eyes. And also this is like the larynx, so their larynx can close up. And that's why we get very worried about these patients, because they can just obstruct their airway. Cool, groovy. But I think like it's so much easier when you've seen it, like in like, yeah, if you've seen it. So neurogenic shock is essentially where you've got a spinal cord injury above the level of T6, which interferes with your sympathetic chain. So your sympathetic nervous system maintains like your blood pressure, stimulates your heart. So any kind of disruption to that, they can become profoundly bradycardic. They can become like they can drop their blood pressure, and so that's like a big worry for someone who's like had a spinal cord injury. And so with our surgical sieve, I think I'll go through it because in general it's kind of like anything that causes injury to the spine, so it's not too kind of it's a bit more straightforward. But essentially, if you've had a cut off of the blood supply to the spine, general and spinal anesthesias cause it to a degree. So when you're on anesthetics, you'll notice that when they put the patients under, they'll drop their blood pressure, and that's quite normal. But they obviously drop it to the point where they're not gonna, that it's like still an okay level, but they'll monitor it quite closely. Any kind of like car accident or like trauma can cause it. There's a few kind of weird and wonderful autoimmune conditions that can cause damage to the spine, but those are going to be much lower down on your differentials, and I think we'll just go over them another time. And then obviously any kind of like metastatic cancer or any kind of thoracic tumors that might damage the sympathetic chain. And then, yeah, so there's some of these I've put in multiple categories, and that's just because like people's preferences can be different. Because, for example, Guillain-Barré is a neurological problem that we can go over another time that's caused usually by an infectious agent that kind of brings on an autoimmune process. So if you see them in different categories, like don't get phased. It doesn't mean like you're wrong. It's just wherever you think it fits better. And the classic signs of neurogenic shock is it can kind of be called like warm shock. So they're peripherally like can be warm, but they're profoundly bradycardic, they're profoundly hypertensive, and they get sick very, very quickly and deteriorate rapidly because it's lost that nervous stimulation. So my management, I am not an ITU consultant, and I think that in fourth year, just recognizing the signs of a lot of these is like, just you're doing a fab job. But in general, you're going to follow your ABCDE approach. And that is like the top like thing to do is like your first thing to do essentially. And that's kind of what they'll expect you to do. So if someone's in shock and their GCS is dropping or they're unconscious, you're worried that they're not going to be managing their airway. So you're going to get anesthetics input. If they're not breathing properly, you're going to want to know, is there any chest pathology that's limiting their breathing if they've got a pneumothorax? You're going to want to, so what I meant to write with this is that like you're going to manage their blood pressure before their heart rate. So you're just going to want to give lots of fluids, basically, like try and increase that intravascular volume that they've reduced. And also it's a good idea, especially in hypovolemic shock, is you'll see the doctors do it. They'll do a group and save. So they'll get the patient's blood type and they'll cross match blood as well, or they might just get a whole bunch of O negative blood and give it. And you sometimes might witness this, but they'll do like a major hemorrhage protocol. And we won't go over that today. I think you can probably read up on it in your own time, but essentially it's like you're trying to quickly replace the blood that they've lost. And then if patients are really, really sick, they'll call intensive care and basically provide inotrope support, which is essentially drugs that increase your cardiac output, and vasopressor support, which is just drugs that constrict your blood vessels and like keep the kind of blood pressure up. But I wouldn't say that this is like absolute core knowledge for you at the moment. I think it's just to be aware that obviously like intensive care have access to quite powerful drugs that you wouldn't do in like ordinary resus. And this is for your own time because it's utterly boring and quite tedious, but anaesthetists love it, and it is utterly sensible, to be honest. But you can essentially classify shock on like kind of how much blood volume you've lost by the clinical picture. So if they are lethargic, they'll have lost a hell of a lot of their blood volume, and like will be hardly perfusing their brain and will be low consciousness level. The one trick is that a friend pointed out that to work out the kind of classes of shock, if you look at the percentages, they're like tennis scores. So 15, 30, 40, like if that helps you remember it. And I think with this, it's just really understanding the physiology helps. You don't need to know like all the ins and outs of the arterial system, but just understand that either there's a problem with the pump, or there's a problem with the vessels, or there's a problem with like the nerve supplying them. Yeah, so I think just go over that slowly in your own time. And I think when you do your anesthetics block, they're always up for chatting about it. They're very physiology driven as a specialty, and will be happy to go over it with you. Yeah. So like take home messages, as what I've just said about like understanding the mechanisms really helps. I think being very working out categories and being quite methodical about it is useful. That the blood pressure control is key here, so they will be pushing fluids immediately and sorting out replacement blood. And that there can be multiple things going on if someone's got a background of heart failure and they're dehydrated. You know, there can be not just one of these pictures going on. And just the early recognition is really important, and that's why they do their news scores. They see how patients' sats and observations are going over time. And like that can be really helpful. So even if you're not seeing acutely unwell patients, do have a look at those scoring systems, just to have a look at like how a patient's doing, how they've improved since admission. So yeah, I feel like it's quite a broad topic. Does anyone have any questions?
If you have questions, pop them in the chat and we'll answer them as we go along, just so we can finish on time. So we spoke about pre-renal AKI. So Izzy's just given like that's almost everything you ever need to know about shock for year 4. So shock is really important, and it comes up in every single specialty, so learn about that. The other really important cause of a pre-renal AKI, so you can have like a systemic reduction in perfusion of the kidney, or you can have like a localized reduction in the perfusion of the kidney, and this is called renal artery stenosis. So briefly, 9 out of 10 cases are due to atherosclerosis, so you have your classic vascular path, someone who's pretty unhealthy, smokes, might be diabetic, that kind of picture. 10% are like these young female patients, and they have this thing called fibromuscular dysplasia. And with renal artery stenosis, the main thing to remember is they have this triad of hypertension, chronic kidney disease, because they just keep getting recurrent AKIs, and they get flash pulmonary edema. I should have put an image of the Flash here. That would like to make it superhero themed. But so sometimes you'll start them on like an ACE inhibitor, and they just end up in really, really bad pulmonary edema, and they'll get like admitted to like HDU at least. So it's really bad. So it's just something to keep in mind. It's not that common, but something. The atherosclerotic disease is quite common. So yeah, pre-renal AKI. Think about all the causes of shock, and just have this in the back of your mind. Here are the X-ray findings for pulmonary edema that we're not going to go through today, but for your reference. Causes of intrinsic renal AKI. I would ask you to list the causes, but I thought this would be a useful place to do some signposting, because you can go. Renal medicine is really, really complicated. There was a study like a few years ago. On average, renal patients are more complex than any other medical specialty. But like, you don't need to know that much about the actual renal pathologies. So the things I would really focus your learning on in terms of intrinsic renal problems are acute tubular necrosis and acute interstitial nephritis, which we'll go over today. Diabetic kidney disease is pretty important. I won't go over it today because you need to know about it in terms of how do you manage chronic kidney disease rather in the terms of an AKI. Microangiopathic hemolytic anemia is a huge topic that we'll do another day, but basically, if you block off the tiny vessels within the kidney, you're going to roger the kidney. And you'll get teaching on glomerulonephritis, which is basically inflammation of either the glomerulus or the kidney nephron. And glomerulonephritis is this huge topic which just doesn't come up in exams. It's all the weird and wonderful stuff that I found really interesting, but it's generally not worth your time to learn it in too much detail. Izzy, I don't know what you think about that, but did you learn much about glomerulonephritis for exams? You're muted, sorry.
So, I mean, I love rheum, so I did like of my own accord because I'm like a sado, but like I missed out on renal, and I think that like really it's a tiny aspect. It's a complicated aspect, and I think people spend so much time learning it when actually most of the time they're just asking about AKI and CKD.
Yeah, you can learn it. It might be one question. So glomerulonephritis has all the exciting stuff like vasculitis, anti-GBM or Goodpasture's disease, and like all the various types of lupus nephritis. But yeah, it doesn't come up that much. So acute tubular necrosis and acute interstitial nephritis are two basically drug side effects mainly. There's some other things that can cause them, but the important stuff is the drug side effects. What drugs cause these? With acute tubular necrosis, you can either get it due to drugs or you can get it due to kidney ischemia. So AKI, like getting like shock, can cause this as well. And with this, the kidney tubule literally breaks down, which means part of whatever you're filtering passes through into the urine. Does anyone know any toxins that can cause this? So any drugs we give people that can cause this? So what drugs are nephrotoxic? You have like a 50-50 chance. Yes, so gentamicin is a classically nephrotoxic drug, and that's like the most important cause that you should think of for exams. It's the same reason we monitor gentamicin so vigorously. We check the levels like every few hours after giving them a dose, because we don't want to like ruin their kidneys. Other important things are radio contrast. So before someone has a CT scan, you want to check their kidney function. This is the reason you do not give people with chronic kidney disease radio contrast for CTs. Myoglobin, so the breakdown product of your muscles, is also very toxic to your kidneys and can cause this picture. When do you get lots and lots of myoglobin in your blood? And so when would you get this happening? So there's a condition, rhabdomyolysis. So all of the muscle in your body begins to break down, and there are two you can get it in extreme starvation as well, as your muscles start to break down as a resource because you need the protein within them. Okay, so let's talk about rhabdomyolysis super quickly. So what are the two most important causes of rhabdomyolysis on like a general medical ward? One of them is very medical. One of them is a bit, you can common sense it. So there's a set of medications that cause rhabdo. Does anyone know which ones those are? Pretty rare. Statins, absolutely. And it's like, this is like another classic exam scenario. There's a patient who's taking statins, and then they're given like a P450 inhibitor like clarithromycin, and then they go into rhabdomyolysis, and it's like, oh no, why have you done this? So yeah, statins, really big cause. The other thing is a bit more mechanical. So I for example, I had a patient today who had a lot of falls, and then after one of her falls, she was taken to like the hospital, and she's got like acute tubular necrosis. Why do you reckon that is? Any ideas? She's had a fall. Is getting... So that's a really good idea. It's actually simpler than that. Avascular necrosis tends to refer to, it could cause it. The answer is just trauma. So if someone's like had an injury, it can cause their muscles to break down. So it's actually simpler than that. Yeah. So this lady just fell onto her leg. She didn't break anything, but she'd basically like ruined like her femoral muscles, and they'd all started breaking down, which was damaging her kidney. But yeah, that's a really good thought process. AVN is very important, and fractures are very important, especially in the elderly. So acute tubular necrosis, remember that rhabdomyolysis and aminoglycosides like gentamicin cause it, and there's the one other thing you need to be able to recognize. If we go back, does anyone know what these are? So this is a sample of a patient. So if you took a sample from my patient today, of her urine, and looked under a microscope, you would see this. Do you know what these are? So the thing of note are the big brown blocks. Yeah, so these are red cell casts. That's exactly what it is. And this, like, they don't ask you that much pathology in like year 4, but like we will point you towards what pathology is important, and this is one of the things that is important. So as you've got tubular damage, bits of the red cells go out into the urine, and they get damaged by the edges of the tubule. So you've got like ragged edges on the tubule, and they form like these red cell casts, and you will see these in the urine. Acute interstitial nephritis is where you've got inflammation of the actual kidney, like connective tissue, like the mesenchymal tissue. And this is actually more common than acute tubular necrosis because some of the causes are very, very, very common. So all of the drugs that we didn't talk about before, we can now talk about. So what other drugs are toxic to the kidney but weren't on our previous list? So what's the commonest group of antibiotics that we prescribe to patients? Penicillin. So penicillin causes acute interstitial nephritis. Patients can have a reaction, can get inflammation within their kidney due to a penicillin. Yeah. NSAIDs can also cause it, absolutely. So NSAIDs and penicillin are your two biggest group of causes. In the notes for this slide, I've put up some other rarer causes, but like if you remember penicillins and NSAIDs, you're good. Infections, staph or infections don't usually go to the kidney, but if they do, they can cause this. And then like another important cause is inflammatory conditions. So any idea of some like inflammatory conditions that cause this? With inflammatory conditions, there's always two answers. So IgA nephropathy actually causes glomerulonephritis, not interstitial nephritis. The interstitium is actually fine in IgA. So immune complex ones, yeah. So yeah, lupus. Lupus is your classic immune complex based disease. Yeah, please note. So lupus is like very important in renal medicine because it can cause glomerulonephritis, it can cause acute interstitial nephritis. It can make you systemically unwell, and it can cause shock. It's just everywhere when it comes to the kidney. So every type of kidney problem you can think of, lupus causes it. Yeah. I mean, lupus causes every single pathology in the body. Like, if you're lucky enough, I'll tell you an interesting story at the end about a patient I saw with lupus, actually. So yeah, the other important inflammatory condition can cause this is renal sarcoid. And does anyone know what this is? So here's some more path. So as I said, path isn't, you don't need to know that much, but there's some stuff that commonly comes up. So if you can recognize it, you've got a mark. Did this come up in your exam, Izzy? Or was it a steroids question?
It did. No, it didn't. It didn't.
This came up in our exam a couple of years ago.
We had diabetic nephropathy that came up in the mock exam on histology, which we can do another time.
Yeah, we'll do like the renal important like path another day. But this is the kidney, but this could happen anywhere in the body.
Should we give like the list of diseases that cause this?
Yeah, we'll go through it in a minute.
Oh, sorry, I didn't realize you had it.
So, does anyone know what the structure is? I'll give you a clue. It can happen anywhere in the body. So this is a granuloma. This is a granuloma. So a granuloma is basically a collection of immune cells that are blocked off from the rest of the body. That's effectively what a granuloma is. So someone who's done immuno is going to correct me and tell me like there's a more detailed definition, but that's how much you need to know. And when you see a granuloma, you want to look at the center of the granuloma and you want to see if there's any gaps. If there's some gaps or some funky patterns in the middle, that means that the middle of the granuloma is necrosing. It's falling apart. And the reason that's useful is because the causes of necrotizing granulomas, one condition should pop to your mind when you see a granuloma with the middle falling apart and necrotizing. Does anyone know which one condition you should think about? Tuberculosis, yeah. So if you see a granuloma and the middle is kind of falling apart, it's tuberculosis. If it's not falling apart and it's nice and regular like it is here, there are two important conditions you should think about, one of which I just mentioned, and one of which is to do with the gut. You might not know this, but you will know this by the end of the year, so don't worry about it if you don't. So celiac is a good idea, but celiac doesn't actually cause granulomas. So celiac is an intolerance, and it's largely antibody mediated. So these conditions aren't antibody. So Crohn's disease. So inflammatory bowel disease splits up into Crohn's and ulcerative colitis. We'll go into this another day, but notably, Crohn's causes non-caseating, so non-necrosing granulomas. Ulcerative colitis does not. And then the other condition with non-caseating, non-necrosing granulomas is sarcoid. And sarcoid can happen anywhere within the body. So it's worth remembering. It's one of those. So yeah, as I said at the end of last session, if you can't think of a cause of something, lupus is always on the list. Sarcoid is always on the list. TB is always on the list. Fine. So granuloma, if you can recognize that, done. Obstructive AKIs, how would you split these up? So we're going to do another. This is the last way of categorizing the causes of something. So we've done functional, we've done etiological. How would you categorize this anatomically? So all of these causes are obstructive. You might not have learned about this. This is just a good way of thinking about this. So if any tube has a blockage, there are 3 possible sites of said blockage. This applies to the GI tract, this applies to the kidneys. So so you could split it up by proximal, medial, distal. So that's what they do with the GI tract, but you can't really do that with the kidneys. So what you can do here is you can split it into something inside, so things like stones, so something within the lumen, something within the wall, or something outside that's compressing the entire tube. And as Jade already said, so something inside could be something like stones or blood clots that can like block off your ureters. What could happen within the wall of the ureters themselves to cause a blockage? So what happens if stuff is inflamed and then kind of fibrosis? What's that called? So you could have a tumor. You could have a tumor of the ureter, and that's really rare, but it is possible. Scarring. So yeah, scarring is important because it causes strictures. So strictures are very common, especially after like procedures. So people with like prostate issues might have a procedure and then they get strictures and then they've got problems. And then what kind of stuff outside the tube can start compressing it? Again, it's like the same categories as ever. You can split these up by the surgical sieve and use vitamin D for each of them. Yeah, so the commonest thing is benign prostatic hyperplasia. So the prostate gets bigger, starts pushing on the ureter. What if it's not benign? Not a trick question. Prostate cancer, yes, absolutely. Cancerous prostate hypertrophy, also known as prostate cancer, absolutely. Here's a few. I can't believe I left off BPH on this list. I will add it on. BPH is the most common cause. Important thing to note, lymph nodes are everywhere in your body, and in hematological malignancies like lymphoma, they get massive and they can compress anything in the body. So outside causes, lymph nodes are always a good shout. And then I won't talk about retroperitoneal fibrosis. It happens with some weird conditions, but that can also like block it from the outside. Renal stones cause renal colic. Colic is basically pain that comes in waves. When you see a patient with renal colic, these are the investigations you want to do. You do the U's and E's to check for an AKI. You're going to dip and culture because there are certain infections that predispose you to renal stones, and the best investigation is a CT, kidney, something bladder, ureter's bladder. That's the one. And CT is really good for renal stents because they tend to be calcium stents, so they light up and they're nice and bright. Management depends on the size. Not going to go through this. You can learn it if you want. It's more a year 5 thing in urology, but like it does come up a bit. If it's tiny, it passes in its own time. Otherwise, you need to find an interesting way of getting it out, and you refer to urology. Here's just a useful thing for reference. Any patient with an AKI, if they are on any of these categories of drugs, stop them, because they can cause renal function to deteriorate. We mentioned the other day, ACE inhibitors are quite interesting because in the short term, they're toxic to the kidney, but in the long term, they protect the kidney. So they're used a lot in diabetes. But yeah, if you see an AKI in a patient and they're on these drugs, ask the doctors why are they still on these drugs, because there should be a good reason. It's one of the useful things you can do as a medical student. And remember that any drug cleared by the kidney will increase in concentration during an AKI because it's not being filtered out. So most drugs are filtered by the kidney. So just keep that in mind when you see someone with an AKI. And like, I think it is important to emphasize, acute kidney injury is not a renal problem. Renal doctors very rarely manage acute kidney injury. It's a general medical problem. So surgeons will be expected to manage it, medics will be expected to manage it. So like, regardless of what you end up doing in the future, you will probably end up managing AKI as a part of that. It's a very important like presentation. So any questions? I'm going to post a feedback form. Sorry, we ran like a bit over. And I'm sure you all want to go and get to dinner. But like, as I say, your feedback is super important. We've already started changing things based on the feedback you've given. I'll post a bit of an update later this week on what we've changed. Just remember that, like,
guys.
Yeah, just remember at the start of the year, your aim isn't to be remembering details. I was saying this to Jade yesterday. The aim at the start of the year is kind of to get an idea of the bigger picture, like an idea of what you're doing, like how you're organizing your thoughts. Like you can learn the details in like the last month or two leading up to exams, because any details you learn now, you're probably going to go on to forget. Like that's because it's a long year. So just try and get your head around important concepts, how to approach things. Feedback link is there. Please fill it out if you can. I'm aware that you probably want to go and have dinner. So if you have any questions, message either of us. Also, if you want to go have dinner, can you fill it out after you've had dinner? Cheeky request.
Yeah, thank you so much, guys. Yeah, any feedback, really great.